in Delhi. And the talk that he's going to give is on the obstructive sleep apnea topic. It is the topic of a joint bilateral program that we are running together. It is a program that is supported by the Italian Ministry of Foreign Affairs and the Indian Ministry of Science and Technology. And we are currently working on the path that can mediate obesity and obstructive sleep apnea. So the present talk is a sort of update on the status of the project. So I introduce Professor Achal Gulati.
Thank you, Leora. Obesity today probably is turning out to be one of the biggest epidemics all over the world, and all the more important because the obesity in children is turning out to be in dangerous proportions. Statistics show that kids who are obese at the age of 6 years, 25% of them would carry their obesity into adulthood. And if you are obese by the time you are 12 years, 75% of these kids would carry their obesity into adulthood. What is obesity? Why are we scared of obesity? Obese children, obese people are more prone for hypertension, they are more prone for diabetes, they are more prone for locomotor disorders. Ultimately, the legs have to carry the weight. And if I am 100 kgs, 50 kg weight goes on one leg, 50 kgs on the other leg. So if 50 kgs is lifted by one leg the whole day, the cartilages tend to get degenerated at a much faster rate, and these issues come up. Apart from that, obesity leads to what is obstructive sleep apnea. All my body tissues become bulky, my palate is bulky, my tonsils are bulky, my base tongue is bulky, so I have difficulty in sleeping. What does this lead to? I have a disturbed sleep. I may be physically sleeping for 8 hours, but my sleep is a disturbed sleep. So what happens when I am sleeping badly? When I am sleeping badly, the next day, my overall attentive period scan is much less. My work output is much less. My overall interest in my subject is much less. This is one aspect. The other aspect is because my sleep has been incomplete. I am working in a factory, I can have an accident. I am driving my car, I can have an accident. Majority of the accidents on the highway occur with the driver dozing off. One are professional drivers because they are driving morning, evening, night, so they doze off. But non-professional drivers like you and me, if I have a disturbed sleep, I tend to doze off while driving. Today highways are becoming expressways. There are no speed limits, 120, 130, 140 you drive upon. The road is straight, and just looking sort of hypnotizes you, and one tends to go into a doze off while driving. And that's a fatal accident which occurs at that speed. Apart from that, obesity also leads to pulmonary hypertension. It leads to my difficulty in moving about, so my work output is less, my business suffers. In a child, what happens? Because my sleep is disturbed, so next day my attention span in the class is much less, my scholastic grades go down. So it becomes a multitude of issues which make obesity a situation which is not good to have. And this, again, I would say, is what prompted us to combine the two things, childhood in children and obesity into one aspect, to see whether we could find a correlation between obesity, childhood and obstructive sleep apnea. As a part of the joint Indo-Italian Health Ministry from Italy and the Department of Science and Technology from the Government of India, a joint project was proposed with Ileana as the principal investigator, Dario and a full team of other investigators along with that. And this, we are doing a series of tests which involve the routine blood tests, the lipid profiles, the sleep studies, the hormonal assays, the insulin and the sugar profile, the entire biochemical profile, to see whether we could find a correlation. And the results are still under study, and we are on the field of analyzing. Coming down to a topic of obstructive sleep apnea and otolaryngology viewpoint. If we look at obstructive sleep apnea, let us have a few things clear first. Obstructive sleep sleep apnea is a common disorder which results from a collapse of the pharyngeal airway during sleep. 1. Significant advances have been made in the evaluation and treatment over the past several years. They are there, but they are still not enough for us to sort out the problem. When we talk about sleep disturbances, what happens? We have 3 issues: primary snoring, upper airway resistance syndrome, and obstructive sleep apnea syndrome. They are basically a phase of a pendulum. Now let us imagine life as a pendulum. We have pendulum going from one side, it swings to the other side. So if I see this is physiology, this is pathology. Physiology is normal, pathology is disease. So when the pendulum swings from the normal toward the disease side, it traverses an arc. So I have a normal individual, I have primary snoring, I have upper airway resistance, and I have sleep apnea. So sleep apnea comes on the topmost level of the disease side and normal. In between we have primary snoring and we have upper airway resistance. So this pendulum is what forms my entire disease process. What is it? We have 3 issues: the respiratory disturbed index, the RDI, oxygen desaturation, and daytime sleepiness. We'll come to each one of them. But if you look at the number of respiratory disturbed indices which are occurring, less than 5 with no daytime sleepiness is snoring, less than 5 with daytime sleepiness, upper airway resistance, and more than 5 as per the current definition with daytime sleepiness and SaO2 levels of less than 19 obstructive sleep apnea. So this is just to get the semantics correct. To add to the further semantics, a few terminologies: apnea. What is apnea? We talk about apnea, hypopnea, hypapnea, so many things. So to get the things clear, what is apnea? Apnea is cessation of the airflow at the nostrils and in the mouth for at least 10 seconds. So while sleeping, if I stop breathing for 10 seconds, that is an apneic spell. What is sleep apnea? 30 or more apneic episodes in a 7-hour sleep period. So if I have in a 7-hour sleep period or 30 episodes of apnea, it would classify as a sleep apnea syndrome. So next term is hypopnea. 50% reduction in the airflow lasting for 10 seconds in the presence of continued respiratory effort is hypopnea. And respiratory disturbance index, what we mentioned before, or the apnea hypopnea index API, is AHI is the number of apneas and hypopneas occurring per hour of sleep. In obstructive sleep apnea, the older definition was greater than 10, but today it has come down even to 5. So this is where we stand as far as our semantics is concerned. So what are the types of sleep apnea? We look at sleep apnea: obstructive sleep apnea, central sleep apnea, and mixed apnea. Now obstructive sleep apnea, what is obstructive sleep apnea? It is cessation, stoppage of airflow in the presence of a continued respiratory effort. Now you must have seen a person who is sleeping, an obese person who is sleeping. What happens when he is sleeping? The first phase is comfortable sleep. Then that's snoring. Then the next phase is the obstruction closes my airway with my effort continuing. This is my next phase. And then comes my other apnea, which is central apnea. Over here, every effort of sleeping, the effort of breathing is stopped. So there is no effort over here. And the mixed apnea is a combination of 2. I have placed a picture of a vacuum cleaner next to it. Why is it? So if we just look at the whole thing, why is it? Now just imagine that you have a vacuum cleaner and I close the opening while the vacuum cleaner is sucking. So what happens? There is a negative pressure which is created. The effort is going on, my nose is closed, my vacuum is closed, the motor is working. So if my nose is closed, this is what is happening. And this is what the principle of sleep apnea is all about. So when there is an intrinsic dyspnea which is characterized by recurrent episodes of upper airway collapse, it is associated with oxygen hemoglobin desaturation and arousal from sleep. Both anatomical and the neuromuscular factors are important. Now how do you look at it? Vacuum cleaner, see a baby breastfeeding. Now the baby is feeding, how does the baby feed? The baby puts the mouth on the nipple on the breast and is sucking inside. And that is what is actually happening in a sleep apnea. I am breathing in, the baby cannot breathe at that time. So when he's sucking in, it's stopped. And the other example is the art of osculation, the art of kissing. There again the same thing is happening, the negative effect being created. So this is how sleep apnea actually in a simple language looks like. So what happens? If we see the pathophysiology, there is an abnormal neuromuscular control of the pharyngeal dilators. Now we have the airway. How does the airway go? The air goes to the nose, it passes to the nasal cavity, clears the turbinates, gets warmed over there, gets moisture over there, flows along the floor of the nose. At the back of the nose, it flows along the palate, down into the nasopharynx, into the oropharynx, and then goes into the trachea. This is a normal flow. But what happens is, this is how it is going as a normal flow. It is entering the nasal cavity through the nose, and this is the back part of the palate. Over here, the palate is bulky. The tongue is bulky. See what is happening. The airflow is being impeded over here. There is an obstruction over here. If you see on this slide, there is an obstruction over here. The same if you see the CT picture. This is the obstruction which is occurring over here, a narrowing area which is occurred in the pharynx. So, an airway narrowing, that is a space occupying lesion which could be there either in form of adenoids or a mass or an edema or fat or bulk, whatever it is, that leads to a Venturi principle. What is the Venturi principle? A negative pressure is created when suddenly the air pressure is released. So, if a gas is passing through a narrow opening into a wide opening, a negative pressure is created. Where is the Venturi principle? Other principle important thing in cryoproof probes. So there also it suddenly reduces the temperature. That's the principle of Venturi. When it is going through a narrow opening and suddenly expanding, a negative pressure is created, and that is negative pressure is the one which collapses all the tissues down, leading to upper airway obstruction. How many people have sleep apnea? According to the older guidelines, like I said, the apnea-hypopnea index was more than 10. So in that percentage, 2 to 4% had the sleep apnea. But the newer guidelines which came across, they reduced the episodes to more than 5, and that brought our incidence from 2 to 4% to 9 to 24%, which is a very high incidence. So it is dangerous for 9 to 24% of the people in our population once they have this, all the issues which come across. So what happens? There are 3 levels of obstruction. One is the retropalatal, palate, behind the palate, retropalatal and retrolingual, behind the palate and behind the tongue, and third is behind the tongue itself. So if you see the airway is going, this is the area which is, if you see this is the palate, the soft palate, and this is the tongue. So the area which is behind the palate is one phase, so the airway goes, and this is the area behind the palate is obstructed and near the tongue is obstructed. So if I see the dilated figure, the palate is obstructing over here and the tongue is obstructing over here. So oral airway as well as the nasopharyngeal airway, both of them are obstructed, leading to the problem. So we have type 1 retropalatal, we have type 2 retropalatal and retrolingual, and we have type 3 which is exclusively retrolingual. So my palate may be bulky, my tongue may be bulky. If my palate is bulky, type 1. If only my tongue is bulky, type 3, and tongue and palate both become the type 2 type of syndrome. So what are the effects? Oxygen desaturation occurs and high negative pressure induces an obstruction over there. To see a flow chart how it happens, if we see that when there is a airway resistance, the nasal obstruction is there, adenoids may be enlarged, tonsils may be enlarged, there may be a craniofacial abnormality. So all of them lead to a nasal obstruction, leading to airway resistance, increased airway resistance. I can have more compliance with the pharyngeal mucosa is soft. This will again lead to airway resistance. I can have a neuromuscular incoordination. My muscles are not very well working because they may be replaced with fat. Again, it will lead to a lower muscle tone. It will lead to airway resistance. So, first thing which comes is an increased airway resistance. What happens when there is airway resistance? There is an increase in the intraluminal pressure and there is a Venturi effect. Once both these effects are there, it leads to the upper airway obstruction, which is the obstructive sleep apnea. But then that is not the end of the game. The end of the game is I have to get out of the thing also. So, when the upper airway obstruction is there, my oxygen levels go down, my CO2 levels go up, I have an arousal. The negative intrathoracic pressure is there, it leads to arousal. The negative intrathoracic pressure increases my cardiac output, my cardiac work, increases my left ventricular hypertrophy. So my cardiac effects start showing in also with obesity, with obstructive sleep apnea. So sleep apnea, apart from the things, also leads to my cardiological imbalances in the form of left ventricular hypertrophy. That leads to a cardiac failure. So apart from that, when my oxygen levels are low, leads to cardiac arrhythmias, to hypertension, can lead to pulmonary hypertension. So those issues are also coming in with my obstructive sleep apnea. Once the arousal occurs, now what happens? My muscle tone increases, my obstruction clears, I go back to sleep, I again snore, and the cycle continues. So it's a big vicious cycle which happens. So if you have seen, you all must have traveled in a train at night or in an aircraft. How does a episode of snoring or sleep apnea look like? That's what this cycle is all about. And once I wake up, my physiology comes back to normal, I recoup, I sleep, and the whole cycle continues again. So that is what my etiopathogenesis is all about. What are the causes? I can have obstruction in the nose in the form of nasal polyps, elevated nasal septum, rhinitis, or maybe post-operative nasal packing. If pharyngeal problems may occur, I can have nasopharyngeal tumors and large adenoids, I can have lingual tonsils, a retropharyngeal mass can be there, a large tongue can be there, micropneumonia can be there, small mandible can be there, or in my larynx I can have tumors, I can have edema. And who are more prone? Male sex, obese individuals, alcohol consumption, and increasing age. So these are the ones which contribute to the whole thing. So what does this lead to? Snoring, excessive daytime sleepiness, obstructive episodes. Leads are less common, would lead to morning headaches, personality changes, intellectual deterioration, depression, abnormal movements, frequent waking up, nocturnal choking, and impotence. So all of them, if you look at it, affect the human life in every angle. So if I look at it, I can have excessive daytime sleepiness, sleep specialists, obstructive episodes, sleep specialists, ENT surgeons, morning headaches, neurology, psychology, personality change, psychology, psychiatry, intellectual deterioration, psychology, depression, abnormal body movements, physician, frequent waking up. Apart from that, my hypertension, pulmonary hypertension, cardiology, and in case I have an accident, a fatal accident, my forensic medicine and my colleagues will also be involved over there. So all these issues come up with that. What are my worries? My worries are these children. These children, if you see, this child was 6 years and 60 kgs. When he was 10 years, this child was 71 kgs. 4 years, 48 kgs. And what happened to this boy? This was his daily attitude. So my worry is, what will this child be when she grows up? And that is why this project assumes a significance. In pediatric obstructive sleep apnea, what happens? I have enlarged mass in the nasopharynx. The adenoids are enlarged. We have, I'll just start on the slide again. The pediatric obstructive sleep apnea is important because we have adenotonsillar hypertrophy present in children till the age of 14-15. We have neuromuscular hypotonia can occur. We have craniofacial syndrome which can occur. So this is how an adenoid hypertrophy would look like. This is how an enlarged tonsils would look like, and this is how a micropneumonia would look like. You see, there's hardly any mandible over here. So this is how the investigation would look like in this child. What is the child present with? Loud snoring, noisy breathing, mouth breathing, growth retardation, repeated chest infection, airway infections, abnormal shyness. Why abnormal shyness? Because the child is not very comfortable, he is obese, he is not very active, he loses his overall intellectual level, so he is scared, shy to interact with other people. Nocturnal analysis, which has psychological bearing, as well as because of a disturbed sleep. Poor growth problems because mouth breathing, snoring also affects his growth patterns. He's a rebellious and aggressive behaviors. Personality changes come in the child. Attention deficit disorder. He's not attentive towards his study, so he fidgets around here and there. So the ADS occurs over there, and academic non-enhancement because of not being able to concentrate in the class. So what are the common associations? Laryngopharyngeal reflux. Because my situation is not very good, my sympathetic parasympathetic situation is not very comfortable. Therefore, the acidic regurgitation occurs. The acid from his stomach tends to regurgitate upwards. It goes and hits my posterior part of the retinoid, my vocal cords, and causes a persistent amount of irritation, sore throat, rawness in the throat. It can also regurgitate into my nasal cavity, into nasal obstruction, nasal edema. All these problems can occur. Systemic hypertension can occur, coronary artery disease, pulmonary hypertension, right heart failure, cardiac arrhythmias, left ventricular hypertrophy, myocardial infarctions, depression, sudden death. You know, in the past, sudden death used to occur and people used to wonder why the death has happened. The individual got up early morning, he just passed away. One of the most common causes for sudden death attributed today is obstructive sleep apnea because of the cardiac anomalies which occur along with that, and regular and work-related accidents which happen. In the history, general appearances are important, weight is important, height is important, blood pressure is important. The history of alcohol abuse, drugs, sedatives, thyroid evaluation, ENT and head and neck evaluation, craniofacial anomalies and morphologies need to be evaluated. So, when you have snoring and obstructive sleep apnea, apart from that, the site of obstruction has to be seen and the associated problems have to be evaluated. These two things are important when we are evaluating for the sleep apnea. Apart from this, we need to do the insulin level, the glucose metabolism level evaluation, we need to do the lipid profile, and we need to do the hormonal acids which are there because they have bearing edge to this. What happens to the individual? If you see an adult, short, thick neck, collar size 17.5 is the ideal thing. What they say more than 17.5 would be a good candidate for sleep apnea. And a large floppy uvula. Now, if you see, this is the oral cavity of the individual. This is the uvula, the thing that hangs from behind. It's a large uvula. You have seen the bulky tongue over here. You see a large tonsils over here. You see the pillars over there are hypertrophied. So there's a big mass inside the oral cavity, and this all leads to obstruction while breathing. And if it is there, a short mandible is there, then the micrognat can also contribute to the whole thing. Investigation. What all we need to get done? Hematological evaluation, ECG, radiological investigation, pulmonary function test, polysomnography. Polysomnography is a gold standard investigation for obstructive sleep apnea. In our project, the polysomnography is an important thing, and we are doing it on a domiciliary basis because a child's full night has to be recorded, and rather than admit the child to the hospital for routine polysomnography, we decided we do it in the house, but in the child's own comfort, in his own bed. So polysomnography is the most important diagnosis test for the diagnosis of obstructive sleep apnea. Overnight monitoring, when we are doing the obstructive sleep apnea study for the sleep study, what all do? We do the overnight monitoring for pulse oximetry, the end-tidal carbon dioxide, ECGs, EEGs, then we can also do the various muscle tones which are there, the anteriotibialis, electromyographies can be done, electroculographies can be done, the eye movement to detect whether it's a REM sleep, the rapid eye movement or the non-rapid eye movement sleep, what phase of sleep is there, nasal and the oral airflow, the chest and abdominal movements, all of them are recorded during the sleep study. And this helps us to differentiate between an obstructive and a central sleep apnea because we have the full recordings. And it also evaluates the severity. What other investigations can be done? We can do a normal sleep MRI. An MRI study is a dynamic study while the child is sleeping or the adult is sleeping. We do an MRI study during his sleep. It's difficult to do it, so we induce sleep. So we can induce sleep with proper food and then do the MRI over there. A sleep MRI can be done and we can evaluate the various palatal movements and the soft tissue movements which are there. We can also detect the various types of whether it's a retropalatal type 1 or it's a type 2 which is a retropalatal and retrolingual, or only a retrolingual with the help of the polysomnography, with the help of a dynamic MRI or sleep MRI. A polysomnography involves the admission, the bed is there, this is the sonography machine, electrodes are put all over and the recordings are done. So when we do the recordings, this is how the recording looks like. The various aspects of the sleep studies are recorded on polysomnography. When you do a sleep MRI, we can also do a fiberoptic endoscopy. Now what we do is while the person is sleeping, we introduce the endoscope through the nose and evaluate his tongue and the palatal muscle movements and the vocal cords and see how much indrawing is there. So that gives us an approximate idea of how much movement and how much obstruction is there. So we can do a direct endoscopy at that point of time and correlate it with the dynamic MRI or sleep MRI studies to find out how much obstruction was there. So how do we go about treating this situation? We can have medical treatment, we can have surgical treatment. In the medical treatment, we have various options. We have appliances which can be used, appliances in the form of nasal sprays can be used, mandibular positioning devices can be used, tongue retaining devices can be used so that the tongue does not fall back. We can have surgical thing in case there is anatomical obstruction. These surgical, we can remove that anatomical obstruction in the form of adenotectomy, in the form of tonsillectomy, in the form of bulk reduction of the tongue. So those aspects can be done. But all these things are going to be superfluous unless you go in for the primary cause management. Weight loss has to be there, the treatment of the systemic disorder has to be there, alcohol advice has to be there, and a drug review has to be there. So the individual has to get across all these problems before he can actually be tackled. And this is an important part because if he is not going to reduce his weight, it's not going to make too much of a difference. Drug treatment. Protocolin has been tried, theophylline, progesterone, and modafinil have been tried with variable responses, but then they have been tried, but they are in the medical management of the whole thing. But as long as the physical obstruction is there, it is not going to make too much of a difference. Then non-surgical treatment. We mentioned mandibular positioning device. This is how a mandibular positioning device is there. The jaw tends to fall backwards, leading to an obstruction. So the jaw repositions it so the jaw gets protruded outward and the obstruction is not there. This has a fairly good compliance rate of 50%, but overall it comes down to 25% because of its effectiveness, number one, and because of the mass which is there. Tongue retaining device. Now what happens is the tongue tends to fall backward. So this is how a tongue tends to fall backward, and we put this mouth device in the mouth so the tongue does not fall backward and it is retained in that position, which will help us. Positional devices, nasal splints. Now we have if you see this part, if I breathe deeply or if I am snoring, so this part flares. So what I do is, this is known as the nasal wall area. So during the snoring effect, my nasal wall tends to collapse and it causes a further obstruction. So if I use a splint to keep my nasal wall separate, the airway is much more smoother. So basically what it does is, it is just widening my airflow, it is smoothing my airflow and leading to a more comfortable. And this is how a nasal splint looks like. This would have been without a splint, and when I put a splint, it has just separated my nasal area. And if you see over here, the space has improved, and this will help to reduce my airway resistance, as a result of which my situation improves. Best treatment would still be continuous positive pressure airway devices which are there, CPAP and a BiPAP which are there. This helps us to evaluate, to manage the situation, because we are giving in a continuous flow of oxygen. If I look at a nasal continuous positive pressure airway, the CPAP, over here I put a nasal mask at night. Now this has comparatively a lesser compliance rate than the normal one, but what happens over here is it is non-invasive and it is effective for primary treatment modality. And what happens over here is that we deliver a continuous flow of air that provides a pneumatic splint. As long as my air is going continuously, the splint, a pneumatic splint, an airborne splint actually is created, and my airway is open. That tends to give a continuous oxygen supply and a more comfortable sleep. This is one aspect. The other is a nasal CPAP, which is there, which comes down to restores my normal respiration during sleep. The same thing with what happens, and it improves my daytime alertness. Once my oxygenation at night is comfortable, my sleep is more comfortable, I have a more comfortable next day, and all the effects of sleep apnea can be reversed. So it can be given either intermittent or it is given continuously. Results have shown that whether it is intermittent or continuously, the results are approximately the same. There is not much of a difference in the end result. Then I have, this is how it looks like. My graph, if I see, this is how it was before my CPAP, and this is the graph after the CPAP I started using. CPAP is a continuous positive airway. This thing, and if you see over here, I have so many, all my records are haphazard over here. I have increased heart rate over here, I have increased heart rate over here, decreased this thing, then I have oxygenation levels are reduced, but after my CPAP, all the flows become more smooth and more organized. And this is why, because once my sleep is more smooth and comfortable, the effects of obstructive sleep apnea are done. Surgical indications. Now when I talk about surgical indications, when do we do it? If my apnea-hypopnea index is more than 15, if my oxygen desaturation comes down to less than 90%, And today, if my AHI is more than 5 or less than 14, with the daytime sleepiness, I go about with it. My upper airway resistance is there, my cardiac arrhythmias are there, unsuccessful medical management is there, type 1 collapse, that is retropalatal collapse is there, and a failure of a compliance with CPAP. If I give a trial with CPAP, only if it fails, then I would have to go for surgical management. But then, what are the surgical management are there? When do I do? If I have extreme obesity, lack of physical activity, alcoholism, and a type 2 collapse, I would not like to do surgical intervention. They do not give very good results. But in other individuals, I would try. When I talk about this thing, nasal surgery in the form of adenotonsillectomy, adenodectomy, tonsillectomy, Uvulopalatopharyngoplasty, uvula, palato, palate, pharynx, plasty. So I shorten out the things and tighten the things so that they do not collapse. Just because we have a bigger bulky mass over here, I am tightening out the tissues over here so that it does not collapse. Hyoid advancement. This is the bone which is the hyoid, and all my tongue muscles are attached to the hyoid. So if I do the hyoid advancement, I pull the hyoid forward, my tongue muscles also get shortened, and therefore I am improving my tongue falling back, and it helps in my obstructive sleep apnea. Midline laser glossectomy. Now because my tongue bulk is more, with the laser I can excise the midline of my tongue and again bring it back with the fibrosis and with the healing, and therefore my tongue gets bulkiness is reduced and my overall situation improves. Mandibular advancement. My jaw is falling backwards, so with surgical procedure I can advance my mandible, leading to an improvement in my airway disease. And if nothing else works, a tracheostomy, I bypass all my oral and pharyngeal airways and I do a tracheostomy and my problem gets solved. That's the gold standard treatment. Not many would accept it, but that is, you bypass the whole thing. Enlargement of the retropalatal airway. I have a palate, behind my palate the airway is less, so I have to enlarge it. So I can do a Uvulopalatopharyngoplasty, I can use it laser, I can use radio frequency, or I can use COBLATION. So these are the various 3 methods where I do my pharyngoplasty. So what I do over here is I reduce the redundant tissue, I excise out the excessive tissue which is there, and once it is done with a good indication and a correct indication, my improvement rates can go up to 85 to 90%. So this forms one important aspect of the surgical management. The success rates in reducing the apneic index are almost on average 50%, but ranging between 23 to 77%. Complications, routine complications of any surgery would be there, would be like bleeding, developmental incompetence, dry throat, etc., etc., etc. So this is how I would do it. I shorten out my palate and suture it so that it is just reducing the bulk. So along with that, I also need to do my mandibular advancement. So when I do that, overall I am increasing the airway space and I am managing it. I can do it using laser. With the laser I can excise the palate and then shorten it out so that reduce the bulk. I can use the anesthetic consideration. Whenever we are using laser, we need to be careful as far as the anesthesia is concerned, because the OT has to be equipped for laser, and therefore all the precautions which are there for the lasers will need to be done. We need to avoid sedatives, we need to avoid narcotics. In case it is difficult intubation, I need to do fiberoptic intubation, and after extubation, I need to maintain the airway for some time with the nasal airway. So this is what we should be doing when you are doing the palatopharyngoplasty. I can use radio frequency to cut it out. So first we use laser, we can use radio frequency. Radio frequency is another tool for giving incision. Apart from that, COBLATION is the third method of doing it. So COBLATION, what happens in COBLATION is that the ionized layer which contains the excited particle, plasma surgery is done, and that tends to heal up, and then when it heals up, the bulk is reduced. So these are various methods for doing it. Other methods for doing enlargement of retrolingual spaces, we can use tongue debulking procedures. The tongue has to be debulked. The mandibular osteotomies have to be done. They can be shortening of the mandible. The hyoid myotomy has to be done. The hyoid bone repositioning is there. The Genioglossus advancement is there. The maxillofacial techniques are there. All these techniques have been described with varying success in varying hands, but then the treatment would still remain the treatment of the primary cause, which is obesity. And when we talk about that, we also have to consider other aspects of obesity management which would come in. So when we talk about the mandibular advancement, we remove this mandible and put a spacer over there to widen it out. So we are increasing the jaw which was small to increase the space over there. And tracheostomy is the last gold standard. But the issue that comes is that this is not the only thing that matters. I will also have to resort to additional surgical procedures like bariatric surgery. Now, to cut down on my weight, I may need to go in for bariatric surgery. You all must have heard the name of Adnan Sami. Adnan Sami was a very famous singer who was weighing almost 200 some kgs, and now he's brought his weight down to 96 kgs after bariatric surgery. He was having very severe problems. He could hardly walk, but he was singing beautifully. Now he's walking and singing beautifully equally. So all these aspects need to be taken into consideration while we are doing surgery. So what matters? If we see childhood obesity is a public health problem, increasing importance, population undergoing cultural transition. Obstructive sleep apnea is a common disease of adult and pediatric age groups. Parents are an important influence. If I am obese, my child would be obese. If I am eating unhealthy food, my child would be eating unhealthy food. If I am not able to convince myself, I will not be able to convince my child to cut down on his weight. So it becomes a public health issue. Often the patient is unaware of his condition. A lot of obese patients say it's a normal thing to be obese, and so what runs in my family, I have so many issues. It doesn't make a difference, but it's unawareness, and this is where the message comes. One has to have the principle that a healthy youth will make a strong adult, and that change will always take a time, but you have to begin by taking small steps. So when I conclude out my talk, obstructive sleep apnea is a common disease of the adults and the pediatric age group. Often the patient is unaware of the situation. A detailed history and clinical evaluation is important. A sleep MRI and a fiberoptic endoscopy has obviated the needs for other cephalic measurements which are there. And once we have these studies, we can confirm our diagnosis. A comprehensive team effort and a pre-surgical evaluation to identify the site of the airway is very important, and that team effort, I will again come back to my most pet slide. Who is this team and what is team effort? Again, it's you, my friends. Thank you so much for your patience here.
May I ask you a question?
Yes.
I have seen some work was done from one of our friends, David San, about the reverse causality.
What it was?
Reverse causality, cause, effect in terms of sleep apnea and some other common disorders like diabetes and overweight in children.
Yeah.
In the sense that because of the reduced metabolism over the sleeping time, there is an increased risk of diabetes. So I'm wondering if you have any experience on that, given that India is one of the countries with the highest incidence of diabetes.
When we talk about reverse causality, I presume you're reaching the conclusion that because of the obesity, I am having certain issues which have led to the effects of obstruction, effects of obesity in the form of obstructive sleep apnea, cardiological issues, psychological issues, personality issues. When my problem is sorted out, my airway is better, my oxygenation is better, so my overall cardiological status is also reversed. So that would lead to an improvement in my overall health status. My work output is improved, my daytime somnolence is much less. So once I reverse the causes, my effects are reversed also along with that. I don't know, this is what you meant by reverse causality.
I was thinking, this is one of the, in terms of...
See, because in the study what we have done, few very interesting facts came out. Quite a few children, Liana would bear with me, have an abnormal insulin levels. Normal insulin level would be something like less than 17. But in almost 60% of our children who were obese and who have obstructive sleep apnea, 60 to 70%, the insulin levels are very high in them. 80, 90, 120. Now these individuals are the ones who would be need to be looked after as pre-diabetics. Along with that, we have so many kids who have a total haywire lipid profile. Their cholesterol levels 350, 360, HDL, LDL level ratios are totally reversed. Now, these are the children who are going to have lipid-based or cardiological-based issues. And if this stage we tackle the obesity, these indices are going to come down and we will have a reversal of the effect in the end. And this is what our target population is in this project. If we are able to identify such children, identify the possible causes for that, if we have a media which is there which can help us in tackling that, our problems, our purpose of doing the project is served. We are doing a hormonal assay, radiconectin we are doing because these are obesity related hormones, and these evaluations are being done because there are certain hormones which in rats have been seen that once the levels are high, they also induce obesity. But surprisingly, not many have come out as high levels in our children. These levels have not come out to be very high. So whether it has the same effect in children also as it has effect on experimental animals is still open for discussion in the ways. But at least the insulin levels and the lipid profiles do come down once our obesity and the weight-related problems are controlled. Yeah.
We are eagerly waiting to have all the data in the sense of the children enrolled and all data collected. So which is your forecast about the time of study completion, since your unit is responsible for enrolling children and
Time for?
study completion.
Completion, okay. See, statistically, figures what we had said was that we need 40 children for the study to be statistically significant, but we added another 10 more for any dropouts or anything. So till date, today is December, and we finished 36 children so far, so we are 14 down short the line. I think by March we should finish our 50 children, but I expect that we should be able to continue the study a bit more and increase our study population proportionately till we can manage it. The funds are we have saved quite a bit of funds overall, and we should be able to manage some more patients. But as far as the primary count of the study is concerned, I think by March we should put the closure date on it. For the minimum figure, anything more than that is going to be a bonus for you, Eliana.
Yes, thank you very much.
So there's